low-dose aspirin is as effective as high-dose aspirin in secondary cardiovascular prevention, and yet some doctors continue to prescribe high-dose aspirin in the setting of dual antiplatelet therapy. We're going to talk today, though, about the subject, somewhat controversial. Proton pump inhibitors reduce gastrointestinal events regardless of aspirin dose in patients requiring dual antiplatelet therapy. And to do so, in the April 12th issue of JACC, I'm with one of the authors, Dr. Deepak Bhatt, who is the Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital and a professor at Harvard Medical School. First, why are people still using high-dose aspirin in DAPT?
Sure. So as it turns out, if you look at registry data, even the most contemporary registry data, for chronic maintenance aspirin dosing, there's still a fair amount of doctors that are recommending, or patients that are taking high-dose aspirin, that is 324, 325 a day. And I'm not sure why, because the guidelines no longer endorse that approach. There's no clear-cut benefit of higher dose aspirin in terms of antiplatelet or antithrombotic efficacy. And there's some evidence that it might raise the risk of gastrointestinal bleeding. In fact, the current trial showed that in a randomized fashion. But it's a US thing. That is, outside the US, in general, people are using low-dose aspirin for maintenance therapy for cardiovascular indications. But in the US, for some reason, use of that higher dosing of aspirin for maintenance therapy persists.
Now, what was the genesis for the paper that's being published in the April 12th issue of JACC on PPIs?
Yeah, so this is from the COGENT trial. The initial results were published in the New England Journal of Medicine a couple of years ago. That study showed for the first time that prophylactic proton pump inhibitor versus placebo reduced clinical gastrointestinal bleeding in patients on dual antiplatelet therapy who weren't believed to be at particularly high risk of GI bleeding, other than that they were on DAPT, but these weren't GI bleeders or other populations where proton pump inhibitors previously had been shown to reduce GI bleeding. So that was the COGENT trial. This new analysis from the trial looked specifically at patients on high-dose aspirin at baseline and those on low-dose aspirin at baseline, and found a benefit of PPIs in reducing gastrointestinal bleeding in both those subgroups. The reason we did it was there was a thought, actually, that in the low-dose aspirin arm, maybe the GI bleeding rates would be so low that you didn't need the proton pump inhibitor. But as it turned out, the proton pump inhibitor was of benefit in both those different subgroups.
So is it worth adding this particular agent for any patient who's on aspirin with DAPT?
Well, you know, that's a great question. So to be clear, the guidelines and expert consensus documents in the US and Europe do not support that approach of very liberal PPI for everybody on dual antiplatelet therapy. They support selective use, that is in patients at high bleeding risk, such as those with previous GI bleeding, maybe those with H. pylori, though you'd want to treat that, patients that are on chronic non-steroidal anti-inflammatory drugs or on chronic oral steroids. Those drugs can raise GI bleeding risk, maybe very elderly patients, certainly patients on triple antithrombotic therapy, that is an anticoagulant in addition to DAPT. All those patients, the guidelines and expert consensus documents say should definitely be on a prophylactic proton pump inhibitor. But patients who are lower risk than that, there's no formal recommendation to do that. Although our study actually did include patients like that, not in that former group. It was actually a low GI bleeding risk population, and we still found benefit.
Well, as the editorial comment to your paper notes, there has been a lack of enthusiasm for the use of PPIs in patients on low-dose aspirin. Does that need to change?
Well, I think for patients that are at high GI bleeding risk, yes. Now, I don't want to be too cavalier about proton pump inhibitors, because in the COGENT study, the trial ended up, the company that made the particular PPI went bankrupt, so the trial ran a 6-month duration, but not longer. It was intended to go longer. So we can say from a cardiovascular perspective, the proton pump inhibitor is safe, no clopidogrel interactions or anything to 6 months. And if there was going to be an interaction, you'd expect it to be in that first 6 months after ACS or PCI. So I think it's reasonably solid for the cardiovascular safety. The GI bleeding being reduced, I think that's quite solid and consistent with prior observational series. But what we can't comment on from COGENT is what the risks might be of proton pump inhibitors continued very long term. Right. I don't mean cardiac risks, obviously not GI risks, they're reducing GI risks, but there have been some concerns and reports of C. difficile diarrhea, of increases in pneumonia, increases in fractures. Difficult to know if any of these things are real, because that's based largely on observational data. Right. So if you're looking at older patients on PPIs, well, of course they have more fractures, but maybe that's because they're older. So, you know, we actually need more randomized data to make sure that long-term PPI use doesn't have some of these other off-target, non-cardiac, non-GI sort of bad side effects. So that's why I wouldn't be too cavalier about just saying PPI for everybody forever. But for sure, when patients are at high risk of bleeding, including those at DAPT, especially during a period of intense treatment, I think it's worth weighing their GI bleeding risk and considering a proton pump inhibitor.
I should note that the accompanying editorial comment that I mentioned in the paper is entitled "A Cogent Argument for GI Protection for Low-Dose Aspirin." And so please check out for the main paper and the editorial comment the April 12th issue of JACC for Cardial Source World News. I'm Executive Editor Rick McGuire.